Welcome, everyone. Thank you so much for coming to the webinar today. My name's Daniel Burka. I've been designing things on the web since about 1998, and today I'm the Director of Design and Product at Resolve to Save Lives. I've been working in public health for the last 6.5 years. So today I'm hoping we can have a really frank discussion about user-centered design in public health. Thank you so much, first of all, to the India office of the Bill and Melinda Gates Foundation for hosting this webinar with us. We really appreciate it. And for everyone, especially Jess, for all the hard work they've done putting this webinar together. This webinar is going to be recorded and it will be published later on the Resolve YouTube channel. You'll receive an email with the link to get the recording afterwards. You can also change the language captions under the More menu at the top of your screen. If you click Language and Speech, you can turn on captions in whichever language you want. So it should auto-translate. Quality, I'm not sure, to get all the presentations in your language. So today's schedule is going to be hopefully pretty quick. I'm going to give a very short intro. Then we're going to have two brief talks, followed by a panel discussion. I want you to get your own questions ready to ask during the panel, and I'm going to do my best. Whatever questions you put into the Q&A section or in the chat, I'll try to bring those to the panelists so they can answer them for you. So, user-centered design, that's what we're all here to talk about. It seems like common sense. Everyone wants to make software that users are going to love and which generates high quality, actionable data. So what's the problem? Why is user-centered design still really rare in the tech and public health world? When I started working on digital tools for managing hypertension and diabetes in places like India and Bangladesh, the challenges for healthcare workers are right in your face. So if you visit a clinic in India, healthcare workers have less than 3 minutes per patient. And in Bangladesh, they have less than 2 minutes. An individual healthcare worker will see 120 patients a day. They're just streaming through, and healthcare workers are trying to manage the patients and treat them and record data into software. Digital tools, for the most part, were not made for this type of high-speed patient care with really busy healthcare workers. And when we talked to lots of healthcare workers, when we started working with them, and you ask them, what can we do to make your life better? 9 out of 10 healthcare workers will say, don't make my life harder. That's the reality of the current situation of tech in health. Even in America, where clinicians have 15 to 20 minutes per patient, clinicians feel like EHRs just eat up way too much of their time that could be used for patient care. Healthcare workers didn't come to work to enter data into computers. They came to treat the patient sitting on the table across from them. But software developers and health officials who make this software, they're not jerks. They want to make digital tools that work and that healthcare workers like to use. So why is software often too difficult to use for healthcare workers? Is it possible to make digital systems that healthcare workers will actually like to use and which generate high quality data for program improvement? I think so, but it's really, really hard. And so we've written a playbook at Resolve about this, which I'm going to put in the chat. And that's what we want to gather this group of amazing experts here today to discuss. Is it possible, and what do you need to do to make healthcare software that actually works? We're going to start off with 2 speakers. Suhail Bidani from the Bill and Melinda Gates Foundation is going to go first, and then we'll follow up with Dr. Tom Frieden from Resolve to Save Lives. Suhail is the lead for digital at the India office of the Bill and Melinda Gates Foundation. He's responsible for digital interventions across the foundation's programmatic work in India, which is vast. And Suhail spent more than 23 years working on digital for development initiatives across 25 countries in Asia and Africa. So I'm really excited to hear what you have to say about user-centered design. Suhail, the stage is yours.
Thanks, Daniel. First, I want to thank the Resolve team for bringing all of us together for a very important topic. I actually just want to start with two stories. The first one is we often go to fields, right? At least I try to go to the field, speak to the users, the target beneficiary groups that we work with. And often we would ask the frontline workers to just demonstrate what digital health app they're using. And more than the times that I would want it to be, they would struggle. They would struggle in terms of just flipping through the various options, screens, explaining it to us. And when I asked the partner concerned supporting the program on have they been given any training yet, or when was it last that they were given the orientation session, often the answer is yes, we did multiple trainings for them, but it's a competency gap, and they just don't get it, and we just need to spend some more time giving that handholding to them. Coming to think of it, very rarely I've heard that there's a problem in terms of the design of the app itself. And I'll pause my first story here. I'll share the second story and stitch it all together. The second story is a personal story for me. My mother was 64 years old and my daughter was 2 years old. Both were exposed to WhatsApp at the same time. And it was very interesting for me to just observe how they were using WhatsApp. I didn't really spend time teaching them how to use WhatsApp. My mother would typically use the short characters used to the SMS way of sending messages. Obviously, she'll forward all kinds of videos to our family groups. But my daughter, interestingly, who was 2 years old, had learned how to speak, but not how to read or type. She would tend to send voice messages. She learned very quickly just how to send voice messages and use emoticons. And that was a contrast which was very fascinating for me, because here were two completely different profiles of users who were using the same platform in a very, very different way. And it was so intuitive for them. And I'm going to bring back the first story now, where I'm sure all of you can relate to these stories. At some point or the other, you would have seen something similar. And you tend to question, why can't we have apps which are very intuitive? Until a few years back, at least, the digital health applications being introduced and being the frontline workers being asked to use those applications, but possibly using the phone itself for the first time in their life. And on top of that, you have a really badly designed application, or even if it's not really badly designed, a not so great application, and they would struggle, right? It just puts them off. The first experience is not great. So you just need to figure out what can we do to just simplify it for them. Also keeping in mind that, often, and this is not me preaching to anyone, I think we've heard enough on, are we talking to the users? But my key question is, are we listening to what they really need instead of talking? Do we design tools which are only for administrative purpose? Or is it a job a tool for them? I think these are important questions which we need to discuss, deliberate, figure out ways to solve for some of these challenges. And I'm looking forward to the discussion. I'll pause here. Back to you, Dan.
What a great introduction. I think that really sets the stage for what we're going to talk about today. So the next speaker, I'd like to bring Dr. Tom Frieden. Tom is the founder and CEO of Resolve to Save Lives, or founder and president of Resolve to Save Lives. He's a physician, an expert in infectious diseases, public health, and epidemiology. Tom was the former director of the US CDC and the former commissioner of the New York City Health Department. Tom knows firsthand how important data systems are for managing large-scale health programs, and how difficult the task is for healthcare workers. So, love to hear from you, Tom. Thank you.
Thanks very much, Daniel, and thanks, Sohail, for a great frame setting in terms of truly user-centered design. I think the bottom line here is that there's a huge gap between what the world knows about how to prevent and treat disease and what it does. That's the implementation gap. There are lots of things that we'd like to know more about, but in terms of doing what works, there's an implementation gap. And the question is, what are the ways that digital tools can help close that gap? And let's be frank, digital innovations in health have fallen far short of what they've promised. Digital tools have revolutionized many workplaces, but in the healthcare sector, there's been a huge overpromising on digital solutions. Electronic health records have not resulted in the kind of step change improvements that we need in most places, and they've been expensive. They haven't worked in most low and middle income countries. Patient-facing tools haven't really had the uptake or impact that we had hoped they would. Hype is the norm, promises of magical systems that'll fix everything. So the question really is, how can digital solutions contribute to closing that implementation gap? And first, they need to be part of a comprehensive program. They're not an end in themselves, they're a tool in service of the program. We focus on technical rigor, operational excellence, political support, and digital systems can be particularly helpful on operational issues. We focus on hypertension for the simple reason that it kills the most people. There are few things that are killing 10 million people a year. Hypertension is one of them. COVID did at its worst. World War II did at its worst. Hypertension does every single year. And that number is going to increase to 14 million in the next generation unless we take urgent action. But we can cut it down substantially if we can do better. Most data systems are cumbersome to use. They don't take the actual working conditions into consideration. They ask for too much data, have too many indicators, and don't focus on the bottom line of outcomes. Everyone talks about user-centered design, but truly user-centered design, what I've learned from the teams, it's very much like good public health and good epidemiology. It's using data loops to consistently and reliably improve the quality of the system. That means that you're getting away from what I saw 25 plus years doing digital design in government, failure after failure with multi-year, complex, expensive processes. Instead, quick assessments of what's working, what's not. And what it results in is better quality and better quantity. For example, in Bangladesh, we've seen a 20-fold increase in the number of patients treated and a tripling in the quality of care. Now, that's not just because of the digital tool, that's because of a comprehensive program, but the digital solution makes a really big difference. And what we're talking about is respecting healthcare worker time. Replace the paper or you're going to double the work. Make it fast and easy to use. Less than a second or 2 or 3 for lookup using a QR code offline. Follow-up appointment data in less than 20 seconds, saving nurses nearly half hour every day with better data, meaningful dashboards, easy training, so there's no formal need for training. You can pick it up and use it just as Suhail's mother and child showed. Minimal data entry means only the indicators needed to improve program. It facilitates but doesn't magically create continuous quality improvement and rapid cycle improvement. Bottom line, the goal here is that a highly successful solution used by healthcare workers to support the care of millions of patients and to improve quality, the concepts of that tool can be infused into other platforms and systems and approaches, not just for hypertension, not just for non-communicable diseases, not just for primary healthcare, but for healthcare programs more generally. Thanks so much, and I'm looking forward to the rest of this discussion.
That was an impressively succinct summary of the challenge and some of the ideas for solutions. Thank you so much, both Tom and Suhail, for your introductions. So now we've got 45 minutes to have a proper panel discussion, and I would love for this discussion to have disagreement and forthright conversation. So as panelists, please feel free to use the raise hand function where you want to jump in and agree or disagree with another panelist's response. We have several panelists, and I want you to introduce yourselves. If we can go alphabetically, first of all, Arti, and then Alain, Marilise, and then Sheila. Please take a minute or two to introduce yourselves and your perspective on user-centered design, starting with Arti.
Thank you. I'm Aarti. I'm a UX researcher and I'm working with DHIS2, which is an open source tool which was created by the University of Oslo. And prior to this, I used to work closely with the Resolve to Save Lives team on their Simple project as their UX researcher. And across both these roles, I have spent a lot of time speaking with healthcare professionals, a diverse set of people from various countries in Asia and Africa, trying to understand what are their biggest challenges in recording data, in managing patients. And it's every day I learn something new, and every day I try to advocate for them to my teams respectively. So, yeah. Do I tag Alan?
I can just take it from there, RT. Hi, everyone. I'm Alan Labrique. I'm the Director of Digital Health and Innovation at the World Health Organization. And designing for the end user is the daily mantra of what we do here at WHO. We're a member state organization. We serve 194 countries, many of whom are asking for technical assistance and support in undertaking a digital transformation of health systems. And so it's really exciting to be part of this this vanguard of a movement, really, of rethinking how we deliver care in remote rural populations as well as bustling urban centers around the globe. And I think the opportunity that we are finally recognizing, we live in a digital age, and the need to reimagine, rethink systems within this framing is what we do at WHO. So glad to be part of this conversation and looking forward to the panel. I forgot who was next in the alphabet. Marlies.
Thank you, Alan. And thank you to Resolve to Save Lives for the invitation to join this discussion today. My name is Marlies. I am with the World Bank, and at the World Bank, I lead our efforts on digital health. The World Bank has invested significantly in digital health in the last decade. In fact, between 2012 and 2022, we invested just over $2 billion in developing digital health systems, many of them health information systems. And what we've seen through these investments is the dual challenge of ensuring that health information systems don't take over the essential process of delivering care. We know that in the US, for example, primary care physicians spend 49% of their day clicking buttons in an EHR as opposed to seeing patients. So how do we design digital health solutions that solve problems and don't take time away from patient care? And second, how do we keep health workers engaged and interested in this digital solutions, that they don't just see it as a mandatory tool for reporting, but that they see the value in digital, in the solution itself, in bringing better value to patients, in making their lives easier. And from our perspective, to realize this potential and to unlock the value that digital has, we really need to think about agency and we need to think about trust. Health workers should understand that they have the power and the ability to say, I don't like this tool or I have this preference. And also in terms of trust, if they don't trust and cannot experience the value that it brings as opposed to one more thing that I have to do in a day, we're not going to see the kinds of engagement rates that are needed. And so, of course, in all of this, user-centered design is absolutely important. And I look forward to the discussion today. Thank you.
Hi, everyone. My name is Sheila McClellan, and I'm a design lead and designer. I've done a lot of research over the years at Google, and we have developed a product called Open Health Stack, which makes it easier for developers building healthcare apps in FHIR. And so one of the resources we have created are design guidelines. So these are a resource for the community to build upon patterns that we have learned can work better for particularly community health workers, but in healthcare workers in general, to build apps that really are human-centered. So super excited about the discussion today and to chat more about how we can actually bring users more into the process of designing products.
Great. Welcome, everyone. So I've got a few questions that I'd like to start off with our panelists, but I want this to be a community discussion. So if anybody who's listening to the panel right now has questions, or if they come up with questions, there's a function at the top that says Q&A. Please put your questions in there. We've got a group of people who will filter through the questions and bring them to the panel. So I'm excited to hear from everybody. I have a few really basic questions to start off with, except they're deceptively difficult. And the first one I want to put to you, Arti, which is, when we're talking about users, who are we talking about? Public health is a complicated play with many actors. So when you're thinking about user-centered design, which users do we mean?
Yeah, I'm glad you're asking this question, because I think the term user gets thrown around very, very frequently. And I think over time, it becomes this hazy sort of an understanding of what a user could be, right? And I think even the most well-intentioned team forgets who the right user is. Sometimes even when we are developing a software, we start alternating the term user for anybody who might have a chance encounter with this software. And sometimes we start applying our own personal experiences and judgments to kind of justify these designs. So to answer your question, maybe I can begin with who the users are not. And these are not ministry officials. I'm just going to drop some bombs, but not ministry officials, not ministry folks, or any sort of experts on field. They bring their own, insights, and very useful insights to the picture, but they are not the users. The users are people who are expected to use the software regularly. And in terms of, in the case of data entry in healthcare, especially, when we speak of users, we are usually talking about people who are expected to do data entry. These could be data entry operators. A lot of times, because health facilities are understaffed, these just might be staff nurses working in primary healthcare facilities. These might sometimes also be midwives, some sort of support staff, healthcare staff working. And we are trying to design simple software for people who use. I mean, I wouldn't say that they are not. They don't have. They have used software previously. They use WhatsApp. They are acquainted with it, but they might not be the most tech savvy people. So we want to keep them in the forefront always when we are trying to design simple software. Daniel.
Right. Thank you. Again, panelists, if you want to jump in, feel free to raise your hand. The next question. Oh, Elaine, go ahead.
No, I mean, I think that's it's a really good question, Daniel, that you've asked, and I think just taking a step back to what Tom was expressing with the frustration of digital really not living up to its promise. I think the key thing that we also need to keep in mind is, as for far too long we've been trying to digitalize paper systems, right? And moving health systems that were designed for an analog world into a digital reality that we live in today. And so when we think about, the increasingly strong digital ecosystems that we're seeing pop up around the globe, whether it's with infrastructure, whether it's with access to technologies, or really robust governance of these digital ecosystems, the opportunity that we have is to question the status quo and to ask, why are we doing things in a particular way, right? Is it because we've always done it this way? Do we have an opportunity to reimagine systems? And that's really comes back to your question on who is the user. And that's who we should be asking about what their expectations are when it comes to seeking care and navigating health systems. We've seen the transition in many other sectors. I think Suhail pointed this out earlier. We don't talk about digital banking or e-banking anymore. We talk about banking with the central tenet, the central expectation of users is to be able to pull out their phone and check their balance, whether they're living in rural Kenya or in New York City, right? And it's just become the way in which people can experience a part of their lives with facility, with minimum obstacles. But I do want to bring up the important point that designing properly, as we've talked about in this theme, is not just about the end user, because it's not just about what you can see. It's also about what you don't see, what's under the hood, if you would, right? And so the way data is being captured, the way data is being stored, how workflows interact with how people expect to interact with patients. So in one of the challenges with, say, electronic decision support tools for the longest time has been that they are, by the nature of the technology, very, very linear, right? You ask this question, then you ask that question, then you ask the next question. But that's not how humans interact with each other. And so we have to be thinking about how new technologies gives us the ways to strengthen how we capture, store, protect data, but more importantly, how we reflect the tools as part of the health journey of a human being, of a person, right? And I think that's when I think about the user, that's really top of mind.
Yeah. Marylise?
And yeah, Daniel, you will learn not to give Elaine and I the unlimited floor. I really want to build on what Elaine said. We know the old adage that if you think technology is going to solve your problem, you neither understand your problem nor the technology. And I think that is so true in the digital health space. I think to Artie's point about who is the user, I agree it is those who individually use the tools on a day-to-day basis. But I would argue that if we focus just on the people part and we don't also focus on the process and the technology part, we're not going to get success either, right? So I like the idea of user-centered design is necessary, but it's not sufficient, is the point that I'm trying to make. We really need to think about system-centered design. We need to think about the ways in which how the software works comes together with all the other aspects of how services gets delivered. It's the only way we're going to move from the paradigm of data for reporting to digital for value. And I think that's absolutely
essential. I'm going to cut you off a little bit, Marylise, before you and Elaine run away with this. So let me reframe what you're saying, actually, because this is one of the questions I want to get to. Interoperability is a huge subject, and Sheila works literally on a FHIR standard, software stack. Elaine, I know you're a big supporter of FHIR. Yeah, you're clapping. Is interoperability human-centered in terms of technology? Like, what is the overlap? Because I think there is overlap between the two. How do you think? I know it matters from a data and reporting perspective, but from a human-centered design perspective, impacting healthcare workers and patients, how do you think about interoperability?
So I'll take a quick stab at that, because I think interoperability is what allows the seamless flow of information between all of these applications and tools that are purportedly built to make our lives easier, right? If we're replacing a reality where a health worker in rural Bangladesh is going from carrying 15 different paper registers to now carrying 6 different devices, or having to open, as we've seen in some countries, 3 different applications to manage the same patient, we've not gotten any better from the way things were. Maybe it's a little lighter in terms of weight for people to carry, but the frustration hasn't gone away. So interoperability means it's that seamless back end integration of information that can be collected once and used multiple times for the benefit of individuals. When I think about my own patient journey and the number of times I've had to either initiate a new relationship with a provider where I've been handed a stack of papers that I filled out a gazillion times before that encounter, but that doctor, because they have not benefited from an interoperable system, needs that information all over again. So it's this idea of really challenging ourselves to put the person, if it's a patient, or the person, if it's a health worker, really at the core of what we're doing. Nobody has more time to spend doing things. If anything, the health systems, the burdens are getting more complex. So we have to be thinking about ways, how can this be made simpler? How can we put less burden on people and on workers? And can technology really enable that from happening? And interoperability is central to that.
Right. Sheila, do you have thoughts on this?
I think one thing that's really helpful or like an approach that can be really helpful when thinking about interoperability is to take design your way through this. So service design, or thinking about how you can blueprint out where these interaction points are happening. And so thinking about the needs of all these different users can be really helpful to map out, and then understand, what is the goal of each one of these different users who are interacting with the data at a different point. But I think when you take what is the goal, and then design around that, it can be really helpful to decomplexify and simplify what actually needs to happen. Because I agree. I think we're asking healthcare workers in general to input way too much data. It's bogging them down, and it doesn't necessarily make a difference. And then really, question every question that you're asking them to complete. What is the meaningful difference asking this question is making in their care journey? Does it make a difference, or does it not?
Exactly. So Sheila, to your point, I agree with you 100%. I think what that implies is when we think about user-centered design, human-centered design, we're not just talking about the software and interacting with a phone or interacting with a computer, right? It is within that healthcare process that we have to think about how digital enables things to be done better and things to be done easier. One of the things that I think we need to get better at doing, and it was one of the Q&A questions, is when we talk about health technology assessments and how, because at the moment it's hard for government to make decisions and to prioritize which digital tools to use to apply and implement first. There's almost this underlying notion that digital is implicitly better, and so therefore, of course, I have to digitize, and I have to digitize everything, But one of the things I think we need to do more is have governments do time motion studies, understand how this technology and how the redesign of the service delivery process is enabling better and faster care to be delivered to more patients. And if it's not doing that, we should ask ourselves, is this digital technology, in the way in which it is designed and the way in which it facilitates the service delivery process or the health system process itself, is that necessarily the right process? I think that has to be an integral part of this conversation, that we can't look just at the user-centered or the human-centeredness of this without looking at the process in which it is being delivered.
Yeah, it's all related.
Yeah.
Alan, if you don't mind, I'm going to jump over
Sure,
you to
sure. That's fine.
Suhail. I'd love you to hear your perspective.
I just wanted to make a short point, and linking it back to what Mary-Lise, Elaine, Sheila mentioned. I think a couple of things, right? One, it's very important that when we are bringing change at scale, and digital health is one of the key examples of change at scale, we have to also question the principles and the status quo. Fundamentally, and going back to the interoperability point that was being discussed. You can't even see that particular application as you're designing it in a silo. You'll have to also see what else is there in the ecosystem which is getting captured. How do we follow the principle of a single source of truth being there? That's where the real power comes in, and that's where the point that Marylee's also made in terms of just understanding how the process also will be seen from a design thinking perspective is important. I also appreciate the point on agency and trust that was brought out. Somewhere that agency is very critical, and trust for me is also a slightly bit different connotation in terms of just ensuring that we have no punitive actions being driven through that. There's going to be another way to just ensure failure of some of these initiatives. But I pause here. Back to you, Darren.
Great. I want to start bringing. So we've got a few questions here. There's one that there's a perception that human-centered design solutions require a lot of funding, and that generally there's a paucity of funds in healthcare, public healthcare specifically. So is user-centered design worth the investment? Marylees, do you want to tackle this?
I would flip that question on its head. I think it is a fundamental question, but I would flip it on its head and saying, what is the cost of designing software that no one wants to use? I have a practical example. One of the countries in which we worked on an evaluation of a new digital health platform. In the beginning, the users were going to the platform and using it and extracting and inputting data and chatting with each other on it on average 8 to 10 times a day. 6 months later, the high volume users were going to the platform once a month. And so the real question is, if that's the speed with which the engagement dropped from 8 to 10 times a day to once a month for the high volume users, the low volume users didn't even log on anymore, then that digital solution in and of itself is a failure. So to me, I think when we talk about, it comes back to the point about prioritization and value. When we do health technology assessments, which we need to do a lot more of, they're nascent and virtually non-existent. We don't do cost effectiveness or cost benefit studies of digital solutions. We need to think about quantify the value that these solutions will bring. And when we quantify the value that they will bring, human-centered design, the cost of investing in human-centered design will pay itself off. The return on the increased engagement rates, the return on increased value will pay for itself more times over.
Yeah, reminds me of, there's a quote from a car designer named Dr. Ralph Speth, and he said, if you think good design's expensive, you should see how expensive bad design is.
Yeah.
I'm going to turn this to Arti, because user-centered design and research can be quite expensive, but I think, from what I've seen in your work, Arti, there are ways to make it more accessible. How do you suggest people do user-centered design on the cheap?
I think a lot of times people, like you were saying, right, user-centered design, user research sounds like something that you need to invest a lot of time and a lot of resources and funding, but both at Simple and at DHIS2, we have found interesting ways to work around that sometimes, right? So if there are budget cuts, if we are short on timelines, what are some things we can do? We often rely a lot on, for example, and I'm going to speak mostly about user research. I work primarily in that. A lot of times we think that we require a lot of in-person time with users, and it's fantastic to get that. However, off late, and thanks to, one of the few things that we have to thank COVID for was the introduction of doing remote usability tests and being able to get a lot of time with the actual healthcare professionals and being able to test a lot of our designs and concepts without having to really spend too much in accommodation, transportation, etc., all of that. The other things that we have also been doing is that trying to find alternatives, the next best alternatives to actually speaking with with healthcare workers who are the primary users. And we do that by trying to find the next best thing, which could be healthcare workers working in private health facilities. And these are slightly more accessible to people, say me working in India, and I can then access them, recruit them, and speak to them. Sometimes we also find interesting, slightly not very traditional ways of doing research. I have stepped into cafes in health facilities and try to speak to people at lunch breaks. These are all like very guerrilla ways of testing. Walking into pharmacies sometimes, and then striking a conversation with pharmacists. So there are multiple ways of trying things out, even when finances are sort of limited, and even when timelines are tight.
Right. So another great audience question that I want to direct to Alain and Sheila, I think as a practitioner, I'd be curious in your thoughts on this. Is it possible to set collective standards for user-centered design? Like, could a country set a standard that all health tools must, achieve certain standards in order to deploy software to healthcare workers? Is that a pipe dream? Is it possible?
It's happening right now. I mean, I don't think if we take the expanded definition of what we are talking about when we say human-centered design or user-centered design, we really have to push the boundary of the definition to go well beyond the interface that we're talking about, right? Because I think over the last few minutes of discussion, we've established that bad design is expensive, bad design can kill people, bad design can exacerbate inequity and leave people out, and it wastes resources, right? So one of the things that we've been doing with partners across the ecosystem is to develop exactly that, the reference standards for different parts of the health continuum to identify the various personas to which the design is being targeted, to help define the complex clinical and public health workflows, so that we can not just lower the cost of integrating robust human-centered design into the development of digital solutions, but also help governments have at their disposal the tools that they need to embrace human-centered design as part and parcel of responsible digital health transformation, right? I think what Marlies was saying a moment ago, right, with the counterfactual of what happens if we don't do this, is that we continue to flush millions and millions of dollars that we don't have in the health systems into systems that only last for the duration of whichever donor is funding that work. And countries have come to us and in various fora to say we just simply can't afford that any longer. We don't have the time or the financial resources to keep spending money into systems that don't last beyond the few years in which they've been funded. So it's absolutely essential that we continue to push the importance of this in how systems are built. I will say just briefly, Daniel, there are design standards for inclusion of people with disabilities, of accessibility that have been the standard for those particular population segments for years, if not decades. The same needs to be true for community health workers, for clinicians, for patients with different living with different illnesses. And so, I'm absolutely 100% with you in terms of this is not just possible, but it is happening.
Yeah, it's a really good analogy to accessibility standards. Sheila, do you have thoughts on this? It's okay if you don't.
I think one more element to consider is to be thinking about the ecosystem of applications or other tools that these people are using, because one thing that we have tried to do in our design guidelines, for instance, is to leverage the most common patterns, the ones that we're seeing being used across the board, so that healthcare workers are, they're learning to interact similarly with all these different tools, rather than things being done very differently in all these different applications that they're interacting with. And so definitely thinking about this more at the ecosystem level, or the range of tools that are being used, and leverage what's already working in some application when developing a new application, I think can be really helpful, rather than, be like novel interactions, or let's do things in a way that's unfamiliar to the user.
Yeah, it does feel like everybody's solving patient search in every app, for instance. It's a gnarly problem. It's really hard to get right. This actually brings me to a question I'm particularly interested in. And this is particularly for Sheila and Arti, but others as well. Is in some places, DHIS2 is a good example. The FireStack from FireAPK from Google's another example. There are platforms, but then countries or NGOs are creating their own software based on those platforms. So you have to have good user-centered design in the platform and good user-centered design in the configuration. How is that the platform? How much of that responsibility is on the platform?
I can jump in just with our approach on the Fire SDK, which is a component of the Open Health Stack. So we tried to build out the most common components that we know are used in most community health worker applications, and make sure that those are working well. So, standard components for checkboxes, the way you have multiple choice questions. And I think having the foundation is really helpful for them to build upon for developers building their own applications. So that has been our approach, to be thinking about what is the baseline standard that then can make it a lot easier for individual developers to make sure that they're starting from a good point.
I agree with Sheila, especially with the analogy about the foundation being robust, right? Because if everybody is building over that foundation, and if the foundation crumbles, their programs and implementations are also not going to hold. So it's to answer your question, Daniel. I think it's more important for the platform to be robust and strong.
Great. I want to finish on this last question that Peta Ann just added to the chat. They say, hi, everyone. A topic worth discussing is that the funding of software is generally led by motivating factors of national health departments or private funders. Their focus is usually the bottom line, data, and not the efficiency of healthcare workers and service delivery. I mean, money is often fundamentally at the basis of this. How do you align national incentives or NGO incentives with the need for healthcare workers? Because often there's a broad disconnect. Marylise, why don't you go first?
I agree, Daniel. I think I had to sound like a one-track pony, but I do think it comes back to the issue of value, right? If ministries of health were to prioritize digital interventions based on the most important problems in the country, prioritizing for underserved areas, prioritizing for equity, prioritizing digital solutions, not based on what NGOs or development partners or WHO or the World Bank brings, but based on what are the most critical, pernicious challenges, bottlenecks in our system for which we've not been able to find solutions. If we start from that place, and we had health technology assessment information, we knew what the costs properly were, the total cost of operation, we could compare different interventions with each other and say, maybe an appointment scheduling system is not the most important thing. Maybe we want to focus on AI-enabled radiology because maternal and infant mortality, neonatal mortality is incredibly high in our country. But the governments are not currently always in the driving seat of being able to make those decisions. So we need a lot more evidence and different kinds of evidence and data about how these digital solutions are working, and the courage to say, if a solution is not working, or a solution worked 5 years ago, but it's now outdated and there's better technology out there, we need to be able to transition. But it almost feels to me sometimes like we're stuck in this infinite loop of, there's a digital solution and somebody's got to fund it globally, and it gets rolled out in a couple of countries in 3 pilot areas, and it never gets scaled. And there's another similar solution. Some countries have 30, 40, 50 community health worker applications, right? That sit on some phones of some community health workers. And that to me is where we've got to change the game, so that the money, a dollar for digital health has to earn its keep, because every dollar we spend on digital health, we're not spending on buying a malaria bed net, and by we, I mean collectively, obviously countries, right? So have it earn its keep, and let's not shy away from that conversation. I think that's an essential part. And the other part is, who pays for the digital service? Does a pregnant woman who receive an antenatal care service that is digital and AI built into it, does a health insurance scheme reimburse for that at the same rate as what they reimburse for a non-digital service? We're not having these discussions. Anyway, this is what I think is important.
Amen. All right, Alain.
Yeah, no, I'll keep my answer very short. Like, there's a saying that every system is perfectly designed to get the results that it gets. And when you dig down to the proliferation of poorly designed systems, or systems that haven't survived beyond a few years of their trial period, what were they designed for is the key question that we need to ask, right? Were they designed with local ownership in mind? Were they designed by people who understood the local ecosystem, who took the time to define their users clearly, and to engage those users in the construction and deployment of those systems? And so if the answer to those questions is no, then we can't be surprised when systems proliferate, when systems don't do the magic that Tom was referring to in his opening remarks, and we continue to waste resources. So we have to, and so why are we at WHO sort of working on the government strengthening part, is because robust governance with clarity around what governments want, how they want to achieve those goals, is the first step to creating the ecosystem where you get well-designed systems in place that are serving the needs that country has prioritized, and not donors saying, oh, we want an app that does this, therefore you're going to use this solution. So
absolutely,
it's really that's a critical piece of it.
Suhail?
Yeah, I'll keep it very short. I know we are short on time. I want to end this conversation with a call to action. I'm answering your question with a call to action. A lot of our discussion has been around how we collect the data. But another element is, what do we do with that data? So the call to action is, as we design any solution, any platform, can we just list down for each of the stakeholders, not just the users, each of the stakeholders, what is in it for me? Because that's really important to derive value point that Mary-Lise was talking about. And then funding, I can assure you, there is no shortage of funding. Till the time we are able to convince, there is never shortage of funding. But I'll pause here. Thank you.
Tom, I'm going to pass it to you for the final word. You have a few minutes to say your piece and to summarize.
Thank you very much. And thanks to all of the participants. We heard very powerfully from Arti that user centricity doesn't have to be a huge challenge. There are lots of ways to figure out what's actually happening in the field. We heard from Mary-Lise how essential many issues, including the funding, is. What gets paid for gets done and gets continued. We heard powerfully from Alain the importance of government ownership and government capacity, without which we're not going to reach scale. And we heard from Suhail how value has to be the bottom line. Is it actually improving things? And the fact is, we've heard from Sheila that there are lots of resources that can be used. But I go back to the bottom line, which is that digital innovations in health have fallen far short of their promise and their potential. And one way forward will be to focus laser-like on, is it working for the users? There's the old saying, happy families are all alike, unhappy families are unhappy in different ways. Digital solutions fail in many different ways. Many of them underinvest. They're just massively underpowered for what they're trying to do. The important focus on country ownership sometimes results in an approach that's not scalable or sustainable or reasonable. But that doesn't mean we shouldn't have country ownership. That means we need to walk the path of discovery with countries to understand what's needed, what's possible, how it can happen. And we need to ask really tough questions. We've seen in Simple a product that's been used to support 4 million patients that takes
I think we've lost Tom's audio.
Sorry, is it back?
Yes,
Yes.
you're back.
Yes.
Tom. Thank
Sorry.
you.
Takes on average 13 seconds for healthcare workers to enter follow-up data, saves nurses 24 minutes a day, does in 2 or 3 taps or clicks what takes 2 or 3 hours otherwise, and allows you to improve quality and quantity. So we need to set the bar high, exactly as Marlies has said. Digital solutions need to demonstrate real value, and so far, many haven't. User centricity, government ownership, addressing government priorities, government capacities, addressing the financing of it, all of that is important. But unless we take the bottom line up front and say, is this working for healthcare workers? Is it improving the quality and quantity of care? Is it saving times? Is it replacing paper? We're going to continue to be spending lots of money on digital solutions without getting lots of value. User centricity, really understanding what's actually happening, not lip service to user centricity, but seeing what actually happens every day when healthcare workers try to use the product, that's the way forward. And I really appreciate the interest in this and the collaboration. These are not easy issues, they're tough. Getting this done in low bandwidth environments, getting it done with problems of hardware and software and payment and sustainability and capacity, all of this has led to real overpromising in the digital health space. We hope that we can see a steady improvement in the value provided for the investments given through the central approach of user centricity. Thanks so much.
Thank you so much, everyone. The only thing I'm disappointed about is that this wasn't a 2-hour webinar. There are so many great questions in the chat that we didn't get to, and I had to cut people off in the conversation. These are big, meaty subjects, and we haven't gotten to everything. So apologies if we didn't get to your question. I do want to point out that this is the first in a series of webinars. We're going to do another webinar later this year that's more tactical about actual techniques for creating software that works. And if you pay attention to your email, if you attended this webinar, you should get an email letting you know about the next one. And again, I want to thank the Bill and Melinda Gates Foundation India office and Suhel for organizing this webinar with us. Thank you very much. This has been fantastic. And thank you to our panelists and speakers. This is I've really enjoyed this conversation myself. And again, Jess, thanks for pulling it all together. And to all of our attendees, wonderful questions. I look forward to seeing you again. Thank you, everyone.